Friends, hope you are all doing well. Today our topic for discussion is management of beta thalassemia in pregnancy. Reference is Green Top Guideline number 26 and published in 2014. So we'll discuss the introduction, background and what is the epidemiology. So, the hemoglobinopathies are one of the most common inherited disorders. More than 70,000 babies are born with thalassemia worldwide each other, and there are 100 million individuals who are asymptomatic thalassemia carriers. The birth defect in the thalassemia syndrome is a reduced globin chain synthesis with the resultant red blood cell having inadequate hemoglobin content. So, this is one of your SPA that what is the basic defect in thalassemia, and that there is a reduced globin chain with the resultant red cells having inadequate hemoglobin content. So what is the pathophysiology? The pathophysiology is characterized by extravascular hemolysis due to release into the peripheral circulation of the damaged RBCs and erythroid precursor because of high degree of ineffective erythropoiesis. And what is thalassemia major? Homozygous beta thalassemia result from inheritance of defective beta globin chain. There is beta chain is defective, and from each parent the result in severe transfusion dependent anemia. So the carrier are really asymptomatic and we cannot be usually diagnosed. Sometime in pregnancy, when the pregnant woman came, we with iron deficiency anemia, and when it is a primary. So in that case, if there is iron deficiency anemia, we have to exclude the thalassemia in these type of patient, because worldwide thalassemia is increasing day by day. So and they are asymptomatic, usually they can be missed. So in that case, we will do beta thalassemia. For that we will do HB electrophoresis, and we came to know about that the patient is carrier. But once the patient is carrier, you have to rule out whether what is the status of her husband. If both are carriers, there is increased 25% chance of having thalassemia major. So in that case, you have to pre-conceptual counseling is very important, and pre-marriage counseling is very important, that in every woman or those that are in family, for example, conjunction marriages, in that cases you have to do initially to rule out the beta thalassemia carriers, because when both the husband and wife have beta thalassemia carriers, so there is 25% risk that the baby is having thalassemia major. So in thalassemia major, what is the pathophysiology? That in that the defective beta globin chain from each parent, and the result is transfusion dependent anemia. And what are the heterozygous state? Beta thalassemia trait, thalassemia major, can cause mild to moderate microcytic anemia with no significant determinantal effect on overall health. Homozygous is that in which both the chains are abnormal, but in heterozygous it is a carrier and one of the beta globin chain is defective. So what is thalassemia intermediata? It is defined as a group of patients with beta thalassemia whose disease severity varies. At the severe end of clinical spectrum of thalassemia intermediata, patients are usually diagnosed between the ages of 2 to 6 years, although they survive without regular blood transfusion. Growth and development are impaired. So in intermediata, there is chance that the patient may develop the growth and development are impaired. Usually they diagnose at 2 to 6 years of age, but they survive without regular transfusion. But and thalassemia mania, usually they are asymptomatic and mild to moderate symptoms, so they are usually missed. But in thalassemia major, they are transfusion dependent. So in that case, in major, they required numerous form of blood transfusion. At the other end of the spectrum, there are patients who are completely asymptomatic until adulthood, when they present with mild anemia and splenomegaly, often found by chance during hematological examination or family disease. So they said that some may present in adulthood and some at 2 to 6 years of age. So the diagnosis is depend upon the patient maintaining a satisfactory HB level at the time of diagnosis without the need for regular blood transfusion. So the patient with severe form of beta thalassemia intermediata are those patients with thalassemia major who have poor access to blood were previously offered splenectomy to help reduce transfusion requirement. So splenectomy is no longer the mainstay of treatment for these conditions, but a considerable number of both thalassemia major and thalassemia intermediate patient have undergo splenectomy. So they said that splenectomy is no longer the mainstay of treatment, but some considerable number of thalassemia major and intermediate may undergo splenectomy. So the definitive treatment for the thalassemia, in case if definitive treatment is that is bone marrow transplant. So the concern of modern treatment in beta thalassemia are blood transfusion and iron chelation therapy, because there are so many blood transfusion they lead to iron overload. So in that case you have to do a regular monitoring of her iron level, because the patient may need iron chelation therapy, because if the iron is high they deposit on different organs like liver, kidney, and the other things are reproductive system, like on the ovaries they will affect the ovaries and the testosterone level of the men's. So in that case you have to do her iron levels. Multiple transfusion cause overload resulting in hepatic, cardiac, and endocrine dysfunction. So the anterior pituitary is very sensitive to iron overload, and evidence of dysfunction is common. So puberty is often delayed and incomplete, resulting in low bone mass. So, and most of these women are subfertile due to hypogonadotrophic hypogonadism, and therefore their ovulation induction therapy with gonadotropin to achieve a pregnancy. So this is also one of the important point regarding for the OSCE station. And sometimes the patient may present with infertility, and you came to know about that on investigating the patient. There is hypogonadotrophic hypogonadism. So in history you have to rule out thalassemia, because thalassemia may cause with the increased iron level they affect the pituitary and both the pituitary glands, because pituitary gland is very sensitive to the increased level of iron. So in that case the patient may present with the subfertility. So in that case sometime the patient thalassemia present with subfertility, and some with the already pregnancy had been occur, but in that case they need pregnancy occur, and they need for further monitoring of her pregnancy. So the both cases came as exam in both situations. So you have to make a real concept about that, with subfertility what we have to give these type of patient, and when the patient got pregnant, and what we will do her end organ evaluation is very important. So in both case, when the in subfertility or in when the patient get pregnant, so end organ evaluation is very important, because to check that how many blood transfusions she received, and what about her current iron level, because if increase iron level that will affect her end organs. So in that case you must have to evaluate the patient. So cardiac failure is the primary cause of death in over 50% of the patient, because iron deposit on the cardiac muscles cardiac, so that lead to cardiac failure. Improved transfusion technique are effective chelation protocols have been improved the quality of life and survival of the individual with thalassemia. So the mortality from the cardiac overload has been reduced significantly since the development of MRI method of monitoring cardiac T2 MRI and hepatic iron overload and FeriScan. Liver iron assessment. These methods are now available in large centers looking after patients with hemoglobinopathy. So currently they have discovered these type of things that to check the iron overload, cardiac MRI T2 at the level of T2, and hepatic iron to FeriScan to check the iron overload. Then we will, what are the preconceptional care? What are the additional risks to the woman and baby? So thalassemia is associated with increased risk to both mother and baby. In particularly, there are issues surrounding cardiomyopathy in the mother due to iron overload and increased risk of fetal growth restriction. In this way, with around 9 months or little or no chelation, women with thalassemia major may develop new endocrinopathies, in particular diabetes mellitus, hypothyroidism, hypoparathyroidism due to increased iron burden. So this point is very important in counseling, and both as a structured discussion when you have to tell the patient that what we are going to do for you. So in that case, you have to tell that there are certain impact of this disease on both mother and fetus. So that in an organ evaluation, you have to check her yeah, we will for pre-conceptual counseling, and that you will do her echo to check her for cardiomyopathy, and we will also evaluate her diabetes mellitus, because it will affect her pancreas. The iron may deposit in the pancreas and lead to diabetes mellitus. And it is very important you have to check her thyroid level, because it will lead to hypothyroidism, hypoparathyroidism. In that case, because it lead to diabetes and hypothyroidism, with hypothyroidism the patient may present with the thalassemia along with hypothyroidism. So these patient may present with infertility also. So you have to evaluate the patient pre-pregnancy that the thyroid must be normal. If the thyroid is not normal, then you have to start treatment for both diabetes and hypothyroidism. So these points are very important, that you have to tell the patient that it will have a certain impact on mother and fetus. On fetal is called fetal growth restriction, increased chance of miscarriage, but in mother it will cause cardiomyopathy, diabetes mellitus, hypothyroidism, hypoparathyroidism, and increased risk of thromboembolism is also in these patients. And especially you have to tell the patient initially first trimester you will not give iron chelation therapies, because it will lead to increased risk of miscarriage. So these are the important points you have to remember. What are the optimal preconceptional care for women with thalassemia? At every visit with thalassemia team, there should be a discussion and documentation of intention regarding pregnancy. This should include screening for end organ damage and optimization of complication prior to embarking any pregnancy. Each specialist hemoglobinopathy center should provide guidance for the management of pregnant women with thalassemia. Women which we should advise to use contraception despite the reduced fertility associated with thalassemia. So before that, once the end organ evaluation months is not normal, then you have to advise to use contraception. So, the fertility may be reduced in transfusion dependent individuals where chelation has been suboptimal and iron overload has occurred, resulting in damage to anterior pituitary. These may require ovulation induction or using injectable to conceive. If these patients present with infertility, then you have to start her on. You have first evaluate her and do her FSH, LH level, thyroid level, prolactin level, and if they are compromised hypogonadotrophic hypergonadism picture, then you have to start with ovulation induction, or exogenous you will give a injection gonadotropin to conceive. There is no contraindication to the use of hormonal method of contraception such as COCP, progesterone only pill, implant, Mirena in the woman with thalassemia. So you can give any form of contraception. Then women with thalassemia are best care in multidisciplinary team center including an obstetrician with expertise in managing high-risk pregnancy and hematologist. So the team will provide pre-pregnancy counseling so the woman is fully informed about the pregnancy, its effect, and vice versa. So it is a chronic medical condition, so you will involve the multidisciplinary team, because it is not single domain of the obstetrician and gynae, but involve other specialties as well. That is a cardiologist, the endocrinologist. So you have to mention that we will, when you are starting the management of these patients, so you have to tell the patient that we will involve the multidisciplinary team, and that include different specialties you have to mention in your management. So are there any intervention which are benefit at the preconceptional stage? Aggressive chelation in the preconception stage can reduce and optimize burden iron, body iron, and reduce an organ damage. So you have to evaluate the patient that how much transfusion she has took in last 1 year, and then according to that you will do her iron level, and if needed her if she needs chelation therapy, then you have to start her on chelation therapy. Then why the diabetes occurs? So diabetes the common in women in thalassemia. Women with diabetes should be referred to diabetologist. Good glycemic control is essential for pre-pregnancy. Women with established diabetes mellitus should have ideally have serum fructosamine concentration less than 300 nanomole per liter for at least 3 months prior to conception. This is equivalent to HbA1c level of 43 millimole per mole or 6.5%. We already discussed in diabetes that once she is already established, she's having already established diabetes, then her HbA1c level must be at least 6.7 6.5%, not more than that. And in that case, that they will advise serum fructosamine concentration should be less than 300 at least 3 months prior to conception. So this is one of your SBA, that how much you have the serum fructosamine level, that you have to advise her pregnancies, and how much contraception she needed. So you have to mention that 3 months prior to conception. So in that case, 2 points you have to memorize and remember that in sickle cell disease, we have to mention that hydroxycarbamide can be stopped 3 months prior to conception. And in that case, that in diabetes, you have to advise at least serum fructosamine should be less than 300 for at least 3 months prior to conception. So 3 months, we have read two things in sickle cell anemia, hydroxycarbamide. 3 months before prior to conception you have to stop, and in serum fructosamine level should be less than 300 prior to 3 months prior to conception. Then what about the thyroid? Thyroid function should be determined. The woman should be euthyroid pre-pregnancy. So hyperthyroidism is frequently found in patients with thalassemia. Untreated hyperthyroidism can result in maternal mortality as well as perinatal mortality and morbidity. So the patient should be assessed for thyroid function as a part of preconceptional planning, and if known to be hyperthyroidism, treatment initiated to ensure that are clinically euthyroid. So what about the heart? All women should be assessed by a cardiologist with expertise in thalassemia on iron overload prior to embarking on a pregnancy. So these are the pre-pregnancy counseling. Whenever the patient with the known thalassemia major, then you have to evaluate all the organs stepwise. So then the heart and echo and ECG should be performed as well as T2 cardiac MRI to check for her iron overload. So what are the aim? The aim for no cardiac iron, but taking years to achieve, so care should be individualized. Otherwise, aim for cardiac 2, it should be 20 millisecond whenever possible. At this reflect minimal iron in the heart. So however, pregnancy with successful maternal and fetal outcome occur with lower cardiac T2 values. A less than 10 millisecond is associated with an increased risk of cardiac failure. So a reduced ejection fraction is a relative contraindication to pregnancy, and management should be subjected to multidisciplinary discussion. So this is one of two important point, that cardiac MRI, the T2 should be more than 20 millisecond, and if it is less than that, increased risk of cardiac failure. So it could be your SBAs, that at what level the of cardiac to T2 level, that it increase of cardiac failure, so that it would be less than 10 millisecond. Liver. Women should be assessed for liver iron concentration using Ferri scan. For that, we will MRI scan, and that for liver we will do Ferri scan or liver T2. Ideally, the liver iron should be less than 7 mg per gram dry weight. Liver and gallbladder and spleen, if present, ultrasound should be used to detect cholelithiasis and evidence of liver cirrhosis due to iron overload or transfusion-related hepatitis. So you have to evaluate her viral profile level, because they are due to transfusion dependency. There may be a chance of hepatitis B or hepatitis C. So you have to evaluate her viral profile level. So if the iron exceeds 15 mg per gram prior to conception, the risk of myocardium over iron load increasing. So chelation therapy, low dose deferoxamine should be commenced between 20 and 28 weeks under guidance from the hemoglobinopathy team. So this is the important point, that if the iron load exceeds 15 mg per gram, so you have to do chelation therapy. So low dose deferoxamine is safe. Then bone density scan, because bone are also very affected in these patient. All women should be offer a bone density scan to document pre-existing osteoporosis. Serum vitamin D concentration should be optimized with supplementation if necessary. Then rather red cell antibodies, ABO and full blood group genotype and antibody titer should be measured. Alloimmunity occurrence 16.5% of individual thalassemia. Red cell antibodies may indicate risk of hemolytic disease of the fetus and newborn. If the antibodies are present, there may be change in obtaining suitable blood for transfusion. So this is also very important. Red cell antibodies you have to do prior to pregnancy. Then what medication should be reviewed preconceptually? Iron chelator should be removed, and deferoxamine and deferriprone ideally discontinue 3 months prior to conception. So this is also important, that the three things we have to stop prior to conception. In sickle cell we have already discussed, and in that serum fructosamine should be less than 3 months prior to conception, and you have to stop deferoxamine and deferriprone discontinue 3 months before conception. So these are important, you have to remember. And in that time the deferoxamine are safe, you can give in pregnancy. Iron chelation and with the deferoxamine is safe, but these two are not safe in pregnancy. And they said that deferox and deferoxamine and deferriprone should be ideally be discontinued 3 months before conception, and women converted to deferoxamine iron chelation. So in pregnancy deferoxamine is safe. What are the importance of genetic screening and what procedure involved for that? If the partner is a carrier of hemoglobinopathy that may adversely infect with woman genotype, then genetic counseling should be offered. In IVF or ICSI, with a pre-implantation genetic diagnosis should be considered in the presence of hemoglobinopathies in both partners, so that a homozygous or compound heterozygous pregnancy can be avoided. Egg and sperm donor causes considering IVF should be screened for hemoglobinopathies. So, as we have already read in sickle cell disease, that pre-implantation genetic diagnosis can be done if the both partners are carrier, to prevent later on from the baby with thalassemia. Condition requiring counseling where mother is affected by thalassemia. If the carrier or sufferer condition in partner beta thalassemia, HBS, HBE, delta, HB lepro, HBO, HB, so risk of serious hemoglobinopathies apply to all. So counseling must be done in these cases. And HBC other, risk of mild to moderate disorder. So you have to evaluate for other things. What are the importance of immunization and antibiotic prophylaxis in women who are at risk of transfusion-related viral infection and have previous pregnancy? So both the sickle cell and thalassemia have almost same pattern. What you have to do preconceptually, what you have to do during antenatal care. So these two topics are very easy. Hepatitis B vaccination is recommended in HBs antigen negative women who are transfused or may be transfused. So vaccination for hepatitis B must be done. Hepatitis B C should be determined. You have to evaluate for that. All women who undergo splenectomy should take penicillin prophylaxis or equivalent because they are prone to infection. All women who undergo splenectomy should be vaccinated for pneumococcus and Haemophilus influenza if that had not been done before. So we have already discussed the how duration at pneumococcal will give every 5 years, and Haemophilus and Neisseria will give a start dose, and hepatitis B will also evaluate her for if vaccination has not been done on hepatitis B, then you have to do plan her for hepatitis B vaccination must be done. What vitamin supplementation should be recommended? Folic 5 mg is recommended preconception to all women to prevent neural tube defect. So three things you have to mention up till now. We have in sickle cell disease you will give 5 mg folic acid. Those were obese, and we have already read in PCOS that those who are obese, and the other thing is thalassemia. You have to give 5 mg of folic acid 3 months prior to conception. What about her antenatal care? How is the specialties input delivered for women with thalassemia? Women with thalassemia should be reviewed monthly until 28 weeks of gestation and fortnightly thereafter. So every monthly up to 28 weeks follow up, and then 2 weekly up till the delivery. The multidisciplinary team should provide routine as well as specialist care. And woman, if the preconception counseling has not been done and she came as a pregnancy, then you have to evaluate her end organ damage. You have a baseline testing of all the end organ evaluation. So you have to advise her all investigation in the form of thyroid, liver function test, liver renal function test. You have to evaluate her sugar level, because they are very important. And if the partner screening has not been done, you have to advise our partner screening. If it is not available or the partner screening is unknown, then you have to counsel her regarding for the chorionic villus sampling or for amniocentesis, because if both are if the both are the partner status is unknown, so if maybe the partner could be carrier, so in that case you have to evaluate her for counseling for the CVS, so that there may be chance that the baby may be thalassemia major. So women with and you have to plan then for termination. Women with both thalassemia and diabetes should have monthly assessment of serum fructosamine level and review in the specialist diabetic clinic. If already she established diabetes, then you have to continue her sugar level and start her on oral hypoglycemic agents. But if she is not diagnosed and if her diabetes are controlled and it is normal level, then you have to do her monthly investigation of in the form of serum fructosamine level, because they are more prone in thalassemia. These patients are increased chance of diabetes. All women with thalassemia members should undergo specialist cardiac assessment at 28 weeks of gestation, and therefore as an appropriate thyroid function should be monitored in hypothyroid patients. So initially you have to monitor. So these are the points that you have to remember, that what points you have to remember in antenatal care. So usually this type of station came as a counseling station, so you must remember that at which time what we will do. So you have to tell the patient that you have to come for visit every 4 weekly up to 28 weeks, then 2 weekly, and we have to do your monthly serum fructosamine level, because these type of patients are more prone to diabetes and increased risk of thyroid related thyroid. So we have to monitor her for these type of investigation, because in that case they have a greater impact on her and on her baby. So you have to tell us in systematic form that what we will do. What is the recommended schedule of ultrasound scanning during pregnancy? Early scan at 7 to 9 weeks, and then 11 to 14 weeks. Detail as anomaly scan at 18 to 20 plus 6 weeks. Serial fetal biometry every 4 weeks from 24 weeks, because in thalassemia there is increased chance that the baby may develop IUGR. So you have to do her serial fetal biometry. So how anemia? They said that the severe maternal anemia predisposed to fetal growth restriction in women with thalassemia, and chronic anemia affect placental transfer of nutrients and therefore adversely affect the fetal growth. So this is the point, that how the fetal growth should be affected, because in chronic anemia less chance that the nutrients supply to the baby, so that leads to fetal growth restriction. How should be the transfusion regime be managed during pregnancy in women with thalassemia major? All thalassemia major should be receive blood transfusion on a regular basis, aiming for a pre-transfusion HB of 10. So you have to avoid iron in the form of vinofor or sucrose, because these are at increased risk of iron overload. So whenever the patient HB is less than 10, then you have to transfuse with the blood. Not if there is along with that, with thalassemia there is iron deficiency anemia. If there is iron deficiency anemia, then you have to give uh, iron in the form of IV. But if the iron, you have to check her iron before that. If there is no picture of iron deficiency anemia, then you have to give her a blood transfusion. Women with thalassemia with already established on transfusion regime will generally remain stable during pregnancy. In case where lower pre-transfusion threshold had been used preconceptually, the aim is to achieve pre-transfusion HB of 10. So at least 10 HB should be maintained in these patients. How should be transfusion regime be managed during pregnancy in women with thalassemia intermediate? If there is a worsening maternal anemia or evidence of fetal growth restriction, regular blood transfusion should be considered. If a woman with thalassemia intermediate start transfusion, hemoglobin target as managed are for thalassemia major. So they are both correlated with each other, the intermediate and major. Women with thalassemia intermediate who are asymptomatic with normal fetal growth and low HB should have formal plan outlined in the notes with regard to blood transfusion in late pregnancy. So, in that decision to initiate a transfusion regime is a clinical one based on the woman's symptoms and fetal growth. If the woman is obviously symptomatic, anemia and symptomatic, we have to transfuse her blood. But if she is not symptomatic and the baby is growth is normal, then you have to decide whether she's needed or not, depend upon the condition. If there is worsening maternal anemia or evidence of fetal growth restriction, regular transfusion should be started. Aim for maintenance of pre-transfusion HB above 100. Initially 2 to 3 units should be administered with additional top-up transfusion if necessary the following week until HB reaches 12. So in that case, if evidence of fetal growth restriction because in chronic anemia, the poor lack of nutrients lead to fetal growth restriction. So in that case, you have to give her to build up her HB. The HB should be monitored after every 2 to 3 weeks and at 2 units of transfusion administered if HB is fallen below 10. Every woman hemoglobinopathy fall at different rate after transfusion, so close surveillance of pre-transfusion HB is required. Generally, in non-transfused patient, if HB is above 8 at 36 weeks, transfusion can be avoided prior to delivery. Postnatal transfusion as necessary, and if HB is less than 8, then aim of top-up transfusion of 2 units at 37 to 38 weeks. And that they say that generally if already she's taken, she's already received multiple transfusions, so in that case you have to transfuse her with the so these are two different points. If the patient has already taken blood transfusion in previous year, so in that case you have to transfuse her. In that case you have to maintain her HB of at least 10. But in non-transfused patient, if her HB is 8 at 36 weeks, then you have not to transfuse her blood prior to delivery, because with transfusion it is not as simple that with transfusion there may be certain complications, anaphylactic reactions, and it is a foreign product that you have to introduce into the woman. So you have to be very careful with the blood transfusion, that whom you to get blood transfused or not, because with these blood transfusion so many deaths occur with the blood transfusion, because sometime the patient may get reacted with these, so you have to be very careful. So in that they said that if the patient not already received any blood transfusion, so 8 HB is enough for her, and if the HB is less than 8, then you have to transfuse 2 units of blood to maintain her 37 HB of 37 to 38. So these are the 2 points, the differentiating point that you have to remember. What are the antenatal thromboprophylaxis recommended? So in sickle cell, we have mentioned that when the patient is admitted in hospital, then we have to give her thromboprophylaxis, otherwise not indicated. But in the but we have to start her aspirin from 12 weeks because risk of preeclampsia. So in thalassemia, women with thalassemia who have undergone splenectomy and a platelet count greater than 600 into 10 to the power 9 should continue start her on a low dose aspirin 75 mg. And women who have undergone splenectomy and have platelet count above um, 600 into 10 is the point should be offered low molecular weight heparin thromboprophylaxis as well as low dose aspirin 75 mg. So in that case, and women who are not already using prophylactic low molecular weight heparin should be advised to use during antenatal hospital admission. So these are the special case, they came as a SBA, that if the patient undergoes splenectomy and her platelet count is more than 600 into 10 is the power 9, then you have to start her on low dose aspirin and low molecular weight heparin. So this is the important point for SBA, that whom you will advise both aspirin and low molecular weight heparin, and those that undergo splenectomy and have a platelet count of 600 to 10 is the power 9. And women that not usually low molecular weight heparin, and these when no indication are present for low molecular weight heparin, then in this case you have to advise, when patient is admitted, then you have to give her antenatal hospital admission. So in that case you will give low molecular weight heparin, otherwise it is not indicated. It is indicated in these two special cases as I have mentioned. What is the optimal antenatal iron chelation therapy? Iron chelation therapy is complex, should be tailored to need to the individual. So you have to individualize whether the patient is needed or not. Management of women with myocardial iron. Women with myocardial iron loading should be undergo regular cardiology review with careful monitoring of ejection fraction during pregnancy as sign of cardiac decompensation are the primary indication for intervention with chelation therapy. So, in whom you will advise chelation, the woman at high risk of cardiac decompensation should commence low dose subcutaneous deferoxamine 20 mg per kg per day on a minimum of 4 to 5 days a week under joint hematology and cardiology guidance from 20 to 24 weeks. So if there is a chance of iron overload and there is high risk of cardiac decompensation, so in collaboration with hematology and cardiology, you have to start a low dose of subcutaneous deferoxamine 20 mg per kg for 4 to 5 weeks. So women with myocardial iron loading of more than 20 millisecond do not require the deferoxamine chelation during pregnancy unless there is severe hepatic iron overload. And women with thalassemia major and myocardial iron overloading less than at high risk of cardiac decompensation, which may present as increased breathlessness, paroxysmal nocturnal dyspnea, orthopnea, syncope, palpitation, or peripheral edema. So presentation is a first trimester associated with adverse outcome. So if less than 10 millisecond cardiac decompensation, then these patients may require deferoxamine. So you have to start her in collaboration with cardiology, hematology, that they will start her on deferoxamine. And in pregnancy, deferoxamine is safe. If the patient in pregnancy, patient is pregnant and having a cardiac decompensation symptoms, then chelation is safe in second and third trimester. Then you can give chelation therapy. Management of women with liver iron. Women with severe hepatic iron load should be carefully reviewed and should give low dose of deferoxamine from 20 weeks. So in first trimester you will not give her iron chelation, but from second trimester you will give. It is safe because first trimester will cause miscarriage. High concentration more than 15 are associated with increased risk of MI, and all women with thalassemia. So therapeutic aim for liver concentration should be below 15 mg. What is the best intrapartum management for women with thalassemia major or intermediate? Time of delivery should be in line with national guidance. Midwifery, obstetric, hematology staff should be informed as soon as the woman is admitted to the delivery suite. In the presence of red cell antibodies, blood should be cross-matched for delivery since there may be delay of availability of blood. Otherwise, a group and save will suffice. In women with thalassemia, IV deferoxamine 2 gram over 24 hours should be administered for the duration of labor if the patient need it, otherwise not, depend upon the iron overload. If you are suspecting that that there will be an iron overload, so in that case you will give IV deferoxamine during labor. Continuous intrapartum electronic fetal monitoring should be instituted. Thalassemia in itself is not an indication for cesarean section. Active management of third stage of labor to minimize the blood loss. Postpartum care. What should be the optimum care post delivery? Women with thalassemia should be considered at high risk of venous thromboembolism. Breastfeeding is safe and should be encouraged. So, in that case, what you have to do, the high risk of venous thromboembolism due to presence of abnormal cells in the circulation. So, women should receive low molecular weight heparin while in as a prophylaxis while in hospital. Low molecular weight should be administered for 7 days post discharge for following normal delivery and 6 weeks following cesarean. So this is one of your SBA. They both are same. You have to memorize that in sickle cell disease you have to postnatal you will give 7 days in case of vaginal delivery and 6 weeks following cesarean section in both cases in thalassemia and sickle cell disease. So these 2 points are similar in both cases. Women with thalassemia major who plan to breastfeed should start deferoxamine as soon as possible. Initial 24-hour infusion of IV deferoxamine finish after delivery. Deferoxamine is secreted in the breast milk but is not orally absorbed, therefore not harmful to the newborn. There is minimal safety data and iron chelating while breastfeeding. If woman does not need to breastfeed, IV or subcutaneous deferoxamine are continued until discharge from the hospital or until resumption of her previous iron chelation during under hematologically supervision. So, and the contraception related that we have discussed already in previous slide, that contraception, any form of contraception you have to give in thalassemic patient, but in we have already discussed in sickle cell anemia that in that case we will preferable option in sickle cell are progesterone only based contraception, but in thalassemia you have to give any form of contraception, it is safe. And so this will be the whole topic. Hope you find the lecture good, and in case of any queries तो आप कमेंट कर सकते हैं इस वीडियो पे, और आप व्हाट्सएप ग्रुप पे भी मैसेज कर सकते हैं, ठीक है. एंड hopefully you find the lectures good, and you have to subscribe my channel so that new videos will come, that you will get knowledge from that videos. Okay, thank you so much.